This talk is on the epidemiology of end-stage renal disease. Epidemiology of end-stage renal disease. And what I would like to stress to you is the discrepancy and the big difference between incidence and prevalence of end-stage renal disease worldwide, availability of renal replacement therapy in the West, meaning high economy, and in the East, meaning low and middle economies, and what ESRD in certain countries mean. So ESRD, like CKD, is a tale of two worlds, rich and poor, east, west and east, high economies, low and middle economies. So let's focus on ESRD and renal replacement therapy. First, before we get to ESRD and renal replacement therapy, we need to see where they're coming from and how the incidence and prevalence works out. So the incidence of ESRD depends obviously on the prevalence of chronic kidney disease. Incidence meaning new number of patients per year. Prevalence mean new number of patients, not new, number of patients, total number of patients or individuals in any one time. So if we have a large number of individuals with chronic kidney disease, every year you'll have a high incidence, a large number of patients reaching end-stage renal disease per year, and they will constitute with time a large pool of people with end-stage renal disease or with renal replacement therapy. So general population, the larger it is, the larger the pool of chronic kidney disease, the larger the incidence of ESRD. Obviously, some of patients with chronic kidney disease will die before reaching ESRD. And if we go back to, or you look at your CKD epidemiology talk, you'll find that perhaps up to 10% of the population is labeled as suffering from chronic kidney disease, but only 0.1% reach ESRD. Mainly because many of these chronic kidney disease are due to aging and not progressive, mainly of even some of the referred CKD are not progressive, and also the fact that many with age die before reaching end-stage renal disease requiring renal replacement therapy. And the pool of renal replacement therapy depends on a number of factors. Obviously, the number of patients with ESRD getting into renal replacement therapy. And there are countries where a small percentage of patients with ESRD are offered or have access to renal replacement therapy. Once on renal replacement therapy, dialysis or transplantation, the prevalence, the number of people at any one time on any one of the RRT modality will depend on how many get into it every year, the incidence, and how many get out every year through transplantation, stopping and discontinuing renal replacement therapy, whether because they don't want it anymore or they can't afford it anymore, or shift from one form of RRT, namely dialysis, to transplantation. So death, discontinuation, or transplantation will determine the pool of patients with renal replacement therapy. And also bear in mind that the higher the quality of dialysis, the longer people will stay on dialysis and not die, and therefore the more accessible, the larger the pool of prevalent RRT patients in any given center. And in general, the prevalence of ESRD treated by RRT, providing it's accessible to all, compared to the incidence, is about 8 to 1. So if there is 100 new patients per million of population getting into renal replacement therapy program at any one time, there would be about 8 times as many, 800 patients per million of population being treated by dialysis. In countries where there is no outlet, there's no transplantation, then the ratio can be 1 to 10 or 15. In countries where there is a high death rate on dialysis, or people can't stay on dialysis very long, the ratio can be less than 8, as little as 5, 3, or 1 to 1. People don't stay on dialysis. So it's important to appreciate all these variables, and the Kasky and colleagues paper in 2011 is a good one to look at. Now, if we look at people with ESRD treated and accounted for, you find that the number in 2010 or thereabout nowadays exceed 2 million individuals worldwide treated for ESRD. And the number is increasing, and it's estimated that the increase in any one country or in most Western countries or worldwide is about 5 to 10% every year. We'll come back to the United States because there is there an interesting trend. The striking feature is ESRD and renal replacement therapy in particular is a tale of two worlds, and I've highlighted there North America and I highlighted Africa. The top number is the incidence. So for instance, in the United States, the incidence of ESRD is 336 patients per million of population per year, and the prevalence is higher than 1,400. You can see in some developing countries the incidence is as little as 10. This is sub-Saharan Africa, for instance, 10 new patients per million of population per year, for the simple reason that renal replacement therapy is not afforded, registries are not available, and people die with ESRD without being accounted for, and hardly anybody is on dialysis. And an interesting statistics is that 90% of people on renal replacement therapy live in 5 areas of country, namely United States, Europe, Germany and Japan, Germany and Italy within Europe, Japan and Australia, as well as Brazil. So United States, Europe, Japan, Australia and Brazil. 90% of people on renal replacement therapy constitute about 10% of countries where about 10% of the world population live. 90% of dialysis, where 10%. So the reverse is true. When 90% of the world population live, India, China, Africa, only 10% of world dialysis is taking place, and that's the 90-10 discrepancy. And I'm just giving you an example here, taking Africa, mainly sub-Saharan and North America. If you look at incidence and prevalence of ESRD in high economies, they are listed there for you in the United States, different ethnicity, in Australia, in Japan, and in some lower economies such as Bangladesh, and comparing it with some lower economies such as Bangladesh, just to show you the difference from 350 new patients per year to Bangladesh with only 20 new patients per million of population per year. Compare the prevalence, United States 1,752 at the latest count, USRDS 2012. And look at Bangladesh, only 158, and we'll see why. On the other hand, look at Taiwan, 2,584 patients per million on dialysis. Look at Japan, 2,260 patients on dialysis per million of population at any one time. Causes in the United States, diabetes and hypertension increasing all the time. paralleling the aging of the population. So aging population on the left, increase in diabetes and hypertension on the right. If you look at glomerulonephritis, polycystic kidney disease, interstitial nephritis, they haven't increased in the last 20 or 30 years in the United States, but hardly anybody with diabetes or hypertension used to dialyze in the 70s and 80s, and now diabetes is the most common cause of ESRD along with hypertension in the United States. Hardly anybody over the age of 60 dialyzed in the UK or in the United States in the 50s and 60s and 70s, and now the majority of people on dialysis are over the age of 60, and the median age of dialysis patients in the UK or RRT patient, ESRD patient in the UK is around 64 or 65 years of age. Ethnicity is an important factor, and you can see this in the United States, where there are many, many more African Americans, Asian American, Hispanic Americans compared to Caucasian on dialysis, both in terms of incidence. Second line, you see American Caucasian 295, African American Caucasian 924. Prevalence 1,218 per million for whites, 5,242 for African Americans. Same in Australia. If you take the average, 100 for prevalence, 100 for incidence, 800 for prevalence. If you look at Aborigines, 3 times as many. And this shows in American USRDS data. And I would recommend that you look at the USRDS Annual Report 2012, which should be in your CKD NOC library. If not, it's on of your reference, and it's easy to download on the internet. Causes of ESRD in the UK is similar to the US. Diabetes is rising to the top, glomerulonephritis, renovascular disease is steadily increasing, older age, more hypertension, more diabetes, more renovascular disease. The incidence of ESRD in the US, as I said, reached about 350 new patients per million of population per year. But what is interesting when you look at the bars from 2000 to 2010 compared to 80 to 2000, where there was a steady increase from 2000 to 2010, it looks as if the incidence has stabilized or plateaued. And if you look at the lines showing the percentage increase in every year, and the symbols are to the right, so 10, 15% back in the 80s. If you look at the percentage change year over year in the incidence of ESRD in the US, from 2006, 2008, 2010, there has been a decrease incidence of ESRD in the US. Now, why is that? I'll let you find out, but it's likely that the increase has been due from the 80s to the 90s to an increased recognition, increased lifespan, increased incidence of ESRD. From 1990 to 2000, it seems as if the increased number of incident ESRD may have been due to the fact that patients were dialyzed early. So the total number of ESRD patients may not have changed, but the practice of renal replacement therapy and registry of people starting dialysis were started earlier. So from 90 to 2000, the increase to a large extent was related to the practice of starting people on dialysis with creatinine clearance of GFR around 15 ml per minute. From 2000 to 2010, we probably reach saturation at two levels in the United States. On one hand, there isn't any more aging of the population beyond the current aging. There isn't a steady increase in diagnosed or recognized or treated ESRD as it was the case in the 70s and 80s when diabetics, older people were not reaching or having access to renal replacement therapy. And also the fact that the practice of starting people on dialysis early with creatinine clearance of GFR of 15 and 16 ml per minute has been shown to be not a good policy and not a cost-effective or low-risk benefit practice, and therefore people have reverted to starting renal replacement therapy with GFR, an estimated GFR between 8 and 10 ml per minute. And many of these factors may explain this reversal and this plateauing of incident ESRD in the United States. And we may see it in other countries. And it's something to study and to try to understand and to reflect upon. And for that, I recommend recent publication in 2013 on changing trends of ESRD and renal replacement therapy in the United States. And Rosansky as well as Glasser have published extensively on that trend. Now, if we look at ESRD worldwide and international comparison, incident ESRD on the left, prevalent ESRD on the right, you'll see that the United States, Japan, and Taiwan have high incident as well as high prevalent ESRD. And these are people to a large extent treated by dialysis. So for instance, very few transplantation in Taiwan and Japan, hence the larger pool of people on dialysis. Rising trend of incidence of ESRD in China and Taiwan, higher prevalence of ESRD in China and Taiwan, perhaps due to high incidence of CKD, perhaps due to overexposure to excessive risk factors, including obesity, diabetes, hypertension, but also traditional consumption of herbal remedies, of herbs such as mutong, containing high levels of nephrotoxins, including aristolochic acid. Pockets of aristolochic acid nephropathy in the Far East, in Taiwan, in China, in Central America, and in the past in some pockets in Europe, such as Belgium. The 90-10 paradox that I talked to you about, 90% of people who are on renal replacement therapy live in 10% of populated countries worldwide. By contrast, 10% of people worldwide on dialysis live in the largest low and middle economy, constituting 90% of the population: Africa, the Indian subcontinent, China, and Russia. So huge discrepancy in terms of access to treatment, access in terms of availability of RRT and accountability of ESRD. Now, just a few definitions, and just take GDP per capita, gross domestic product per capita, is a measure of national wealth. Okay, so you would say how much income per individual per year, the higher it is, $2,000, $3,000, $4,000 per year would be a high economy. Less than $1 per day or $365 per year will be poverty and low economies. And we'll see the link between the country wealth, gross domestic product, and the country ESRD, renal replacement therapy, and dialysis facility. Also to take into consideration further down the page is hemodialysis facility funding or reimbursement. Countries where individuals have to pay for their dialysis have very low incidence and prevalence. They may start, but they don't stay on dialysis. Countries where dialysis is fully reimbursed, then they go on dialysis universally and stay on it as long as needed. Countries where it's partially reimbursed, they may start dialysis when they can afford it, but come off after a few months or a year or two when they can no longer afford it. And this is the correlation between GDP, gross domestic product, of any one country and the renal replacement therapy prevalence. So high economies in green, middle economies in orange, and low economies in black, having hardly any renal replacement therapy, low level of RRT prevalence, and the high economies, high level. And again, this shows in this different type of graph showing the high prevalence of renal replacement therapy in the very high economies of Japan and USA, and look at developing countries where instead of having, and again this is an older slide, but the prevalence of Japan, we've seen it to exceed 2,000 patients per million of population compared to 200 patients per million of population in developing countries. Now, why is CKD and why is ESRD in particular and renal replacement therapy neglected in low and middle economies? We have to ask ourselves. There's no doubt that ESRD and renal replacement therapy are very expensive healthcare treatments, and it may or may not feature in the healthcare priority of low and middle economies. First, if we look at overall expenditure on health, if you take the United States, it spends per individual, per American, between $6,000 and $10,000 per year on their health. If you take emerging countries, some of them spend less than $100 per year on individuals' health care. So that's the first thing. GDP is how rich the country, and then depending on the country, wealth or lack of it, they decide how much to allocate of the GDP on healthcare, and it can vary from 8 to 10% of the GDP on healthcare in high economies to less than 1% in low economies. And where does ESRD and renal replacement therapy feature? It's a function of healthcare priorities and the global burden of disease worldwide. And on this slide, which looks busy and complicated, but if you look at the 2010 latest global burden of disease and look at where chronic kidney disease features, it features at number 18 of global death ranks. So the top will be ischemic heart disease, non-communicable disease, ischemic heart disease. 2 will be again stroke. 3 will be chronic obstructive airway disease, chest infection, cancer, HIV. Then we get into diarrhea, diabetes and infections, tuberculosis, malaria, HIV, liver disease, hypertensive disease, cancer, and very low down you get chronic kidney disease. So the country may be poor, but may also have other priorities, and may be poor having a very large population, therefore unable to provide per capita good health care funding, and when they have to prioritize, they look at cardiovascular disease, they look at infection, they look at cancer before they look at chronic kidney disease. Now, if we compare 1990 to 2010, the two panels, you find that chronic kidney disease has come up from the 27th cause of death to the 18th cause of death, but it's still a long way down. Now, the cost. How much does ESRD and renal replacement therapy health care cost? If you take the United States, it's around $30 billion per annum to treat people with ESRD. So on one hand, we have less than 0.1% of the population requiring treatment for ESRD, a very small percentage. On the other hand, the small percentage takes a large percentage of the health care budget, 1 to 2%, at a huge cost of around, in the United States, 30 billion, in the United Kingdom, over £1 billion per year for obviously a smaller ESRD population. So how can we manage that in developing countries where provisions are not available, where renal replacement therapy by dialysis is expensive? This is a slide of Professor Barsoum referring to RRT cost in Egypt, a low to middle economy, and you can see that dialysis, whether hemodialysis or CAPD, is expensive. Around 5 to 10,000 Egyptian dollars per annum, compared to the cost of maintaining somebody with a functioning renal transplant, where the cost falls considerably. So from a cost-effective point of view, the most cost-effective renal replacement therapy worldwide is transplantation and not dialysis. So now let's look at transplantation worldwide. And the left panel, transplant rates per million of population per year. 50 to 60 transplant per million of population, rate per million of population per year in countries such as the United States, Portugal, Norway, the United Kingdom, and so on. And then you go down to emerging countries, Bangladesh, Thailand, Bosnia, Romania, and so on, Malaysia, Chile, much, much lower incidence of renal transplantation. So on one hand, we can't afford renal replacement therapy in low economies. On one hand, the population burden is very high. ESRD is a low priority, as well as CKD in terms of health care, death, and global burden of disease. But also, dialysis is expensive, and the cheaper mode of renal replacement therapy, namely transplantation, is not practiced as well as it should be. So ESRD in many emerging low and middle economy is not treated, and therefore renal replacement therapy is not available, and therefore it's a death sentence. So I recommend that you read Renal Registry, and I've put the top USRDS. Look at international incidence and prevalence comparisons for ESRD. Look at causes and study the USRDS 2012 report very carefully. Your assignment for the ESRD Epidemiology section of the Classification and Epidemiology CKD NOC module is to describe the incidence and prevalence of ESRD in your country. And you may not be able to And one of the burdens and one of the challenges and one of the hurdles you'll be finding is the fact that you don't have a record of incidence and prevalence of ESRD in your country. You don't have in your country a renal registry that documents CKD, that documents the incidence and prevalence of ESRD, and that documents treated ESRD. And as I said, I want you to look carefully and discuss the USRDS 2012 report pertaining to CKD, pertaining to ESRD, and the fact that the trend of ESRD incidence in the United States is plateauing. I also want you to look at the lectures we provided you by the CKD NOC invited faculty and contributor, and read and discuss Professor Richard Glasser's lecture on the timing of RRT in ESRD. Should we start early and give the false impression of a large number of incident ESRD treated by dialysis, as it's happened in the United States between 1990 and 2000, or should we see no advantage in early start and even perhaps disadvantages and risks of early RRT start and start late when the eGFR is between 6 or 8 and 10 ml per minute per 1.73 meter of body surface area. You'll have your MCQ related to the epidemiology of ESRD. And this will constitute the section of your CKD NOC classification and epidemiology module related to the epidemiology of ESRD. Thank you for your attention.